Today we had Dr. Salome Masghati,
Yes.
a gynecologist, a vagina doctor like
Hmm.
me. And in fact, we have a tremendous amount in common because
You do?
we've had OBGYN residencies, followed by, in her case, a fellowship. In my case, there weren't fellowships in my time of coming out of residency. But we essentially did the same of training and being trained in minimally invasive surgery.
Yes.
And I started that myself in the mid 80s. And that was the front line of my practice for over 20 years. And she chose during her residency to go on and do that and get this super specialist and ends up as a super surgeon. And now she's looking at women's health altogether because it wasn't
Hmm.
just gynecology she was doing with the surgery, although it was most of the time. And she's really got involved in functional medicine, hormone replacement therapy,
Hmm.
and I think we practice very similarly.
Yeah.
So it was really fun to talk to her
Yeah.
today. She's so smart, is really passionate about what she's doing, and I'm very pleased to have had her on the podcast today.
Yeah. She's on the podcast circuit now. She's very popular. So we were very lucky to get her. We hope you enjoy the episode.
Dr. Salome Masghati, really nice to have you on the Vagina Doctor Podcast today. We've had a little bit of a conversation previously. We're both vagina doctors. I mean, it's just, and we are named appropriately because that's what we do, but it's also a point of trying to ease the conversation, to bring in real words, real anatomy, and so on, so that it can help our patients and we can communicate with them better. So you're a gynecologist by board certification, but you've done something that I really appreciate because you did a fellowship in minimally invasive surgery. There weren't fellowships in minimally invasive surgery when I was at that stage finishing a residency, but I kind of got that over the years. I didn't do it as efficiently as you, but that was the time. This was really in the 80s when we first started just looking down the scope. We didn't have video cameras at that point,
Yes.
and we had these. We didn't really have any tools until I met some people from Germany who had created a lot of tools. I thought it was Christmas. I mean, there were all these wonderful tools that we could use, and that became the focus of my practice for
Yeah.
20, 25 years. And I loved it. So I appreciate that you did that. I'm envious of having that fellowship because that was a great and a very, very enjoyable part of my life and
Mhm.
doing those pelvic floor surgeries and endometriosis surgeries and so on. Where are you from originally?
I was born in Iran
And when did you come to the US?
about 11 years ago, but actually there was a pit stop in Austria for many years. So I actually grew up in Austria. My parents moved there when I was very young.
Mm-hmm.
So I grew up in Vienna and I went to Medical University of Vienna for med school. So I
Okay.
studied medicine in German, not in English.
Wow. So you have at least three languages then, or maybe
Yes,
more.
yes. I do speak French. I spent a year in France. And then having worked in LA, actually in downtown LA, I learned Spanish because I
Wow.
was mostly Hispanic.
Yeah.
And I do like Spanish. And yeah, so I speak some Spanish as well.
You did your residency though in the US.
Yes, I did my first year at UCLA. I
Mm-hmm.
did some research there and I was accepted into the preliminary position, which allowed me to get into residency, which was very highly competitive for a foreign medical graduate to get into residency. And I did my first year at UCLA and then the remaining years at White Memorial Hospital in downtown LA. It's an Adventist health hospital, so they're part of Adventist Health. And it was a great experience. And then I moved to Las Vegas for my fellowship for minimally invasive surgery.
And who were you working with then? The fellowship program.
Hmm.
Who were your mentors there?
Yeah, so we had Dr. Warren Volker, who was a pioneer of, GYN in Vegas. He created a large medical group that was the largest group back then in Vegas. And then he sold that to a bigger company. And then he created the fellowship because there was such a high volume of surgical cases in Las Vegas. It was very underserved. And then we had our attendings who had themselves completed the program under him. And we had community hospital doctors who were high volume doctors who were part of our training. And then we worked with UNLV. So we had an attending who had come from GW in DC. She had trained under Dr. Mawad and other fibroid and endometriosis experts. And she trained us at UNLV as well.
There's something else that we have in common. I'm a foreign medical graduate also. I went
you are?
to medical school in London, at
Oh,
the
nice.
University of London.
Mhm.
So just another thing. So now you're not doing nearly as much surgery as you used to, and to an extent you regret that. You'd like to get back into a situation where you could do more, and even at least the smaller cases, from what
Smaller
we were
cases.
saying
Yeah.
in our conversation previously.
Mhm.
But you are robotically trained as well,
Mhm. Yes.
which is that's another area of great interest to me, because we were just developing the robot at that
Mhm.
time, and I had the good fortune to be involved with a company called Computer Motion in Santa Barbara, which had a Da Vinci type of robot. It was called
Nice.
Zeus, and in fact, Intuitive Surgical took over Computer Motion a few years later, but I still have connections with the people in Computer Motion and the robotics as it goes on. That's been a tremendous advance, although we were a little, those of us that what we call straight stick laparoscopists that did a lot of surgery kind of looked down on the robotic surgeons, because we felt, well, the robot's only going to slow me down. I can already put a stitch in and tie a knot.
Yes.
So it was sort of a funny time when we were amusing
Yes.
time. I mean, not peculiar. But the other thing that you seem to have moved into is similar to what I've done in my practice. I've been in Santa Barbara for almost 50 years. My practice has grown older with me, which means that most of my patients are elderly, premenopausal, postmenopausal. And so while I continue to want to take care of them, I had to learn more about hormone replacement therapy. And this was 25 years ago, before it was really accepted as a potential treatment. And so now I see that we're both looking into rhythmic or physiological HRT. I've been doing static treatments for a long time, but I'm always interested in new technology, new interests. And so hearing you the other night when you gave a talk on endometriosis and hormone replacement therapy, I thought, again, another connection.
Yeah.
So how and why did you start getting into the hormone replacement area?
When I left the hospital system, I got into functional medicine, which is an approach of medicine where we're trying to address the person as a whole. And we address things like gut health and body systems, whole body system, nutrient deficiencies, and all that. And I did trainings in that. And from there, also learning about how I can optimize the body as a whole, I got into the hormones because these are such an important part of women. And I realized what I enjoy doing the most is taking care of women. Women in midlife is a wonderful, niche that I am so interested in. I've always been interested in menopause. Even when I was 17 years old in high school in Austria, we have to write a dissertation at the end of high school. We have to choose a topic for biology or any topic we choose. And I chose biology, I chose menopause, and I wrote about menopause in women. So I've always been interested in hormones. And it was kind of a very natural transition from I'm a gynecologist, I love women's health. Now I'm doing mostly telemedicine. I left the hospital system. I'm doing functional medicine. One big component of women's health is their hormone health. And the more I'm learning about it, and I'm still learning because there's still areas that are not very tapped into, like early perimenopause, perimenopause later on, how that impacts women's health, the more I'm fascinated with it. So yeah. And then physiologic rhythmic, I got into it through someone called Kristen Johnson, through Wise and Well. Kristen and Maria are two ladies that do amazing work educating women on social media about midlife. They've been doing this over 6 years together, and they wrote a book, The Great Menopause Myth. And when I got to meet them just over social media, I spoke with Kristen, and she educated me about physiologic restoration. From there, I bought T.C. Wiley's book. I visited the Women's Hormone Network website, and I did their course. And I've been working through Harbor Compounding with their course, and I've been working with them prescribing these hormones for my patients.
Well, that's again the way that you and I have met is because of the Women's Hormone Network. Harbor Compounding has been my preferred compounding pharmacy for 25 years or so. And Susie Wiley is from Santa Barbara, and so I had many conversations with her around 2000, 2001, 2002. And she really educated me on it. And of course, the really landmark book of Sex, Lies, and Menopause was just brilliant. My experience with what we called then, and actually still have called, if we stick by that, by her recommendation, what we refer to as the Wiley Protocol. I thought the idea was brilliant. And just for our listeners, I just really want to explain what we mean by that. It is that Susie Wiley felt that the women in their reproductive years were at their best, at their strongest, at their most productive, and at their healthiest. And so why couldn't we continue that beyond menopause by giving them hormone replacement therapy? And she did this by using topical creams of estrogen, progesterone, and doing it in a rhythmic manner to try to follow the 28-day normal cycle of a woman in reproductive years. It sounded brilliant. I thought it was a great idea, but I really had some difficulty with it because it didn't work for everybody. Not everybody liked it. And for the menopausal patients, it of course gave them a period again. And that's maybe one of the good things that most people look at as menopause, that was a benefit. So don't give me that again. And so it sort of fell out of favor with me a little bit until very recently. And talking to Julie Taguchi, a close friend, we've worked together for years, and she's actually been on the podcast previously, and we'll have her back soon again. I understand more of the benefits now, and I think now we have proof that the theoretical benefits from it are now coming to reality.
What's the one thing that changed from Wiley protocol to now?
Basically, an adjustment of the estrogen and progesterone, that the estrogen that is given in the first part of the cycle is a little higher than it was in Susie's description, and the progesterone is a little lower. And that's because we now understand the physiology and how the estrogen and progesterone are being absorbed.
Yeah.
So it's not a lot different, but it certainly piqued my interest again.
I'm on day, let's see, I'm on day 9. I was on a static dose before. And so I'm on day 9 of the new physiological HRT or PHRT. I don't notice anything different yet, but I'm really anxious to see when I go to the progesterone more how I do, because I was always more progesterone sensitive when I was perimenopausal. What have you found with people is there anything that you could share about people that maybe had a really hard time that second part of their cycle with the mood swings and just feeling really emotional? And is the PHRT going to make that come back again, those feelings?
Yes. It can, but the beauty about it is that we can titrate things up and adjust it and individualize it based on
Okay.
the patient's symptoms.
So if I say, hey, I'm starting to feel a little out of control, I haven't felt
Yes.
this in a really long time, then I would go either down a little on the progesterone or up a little on the estrogen.
You can make those adjustments, but also you have to understand when you just start on this, you haven't optimized your receptors and your dosing. So you got to give it a few months and allow this to kind of settle in. And then when you are at, kind of stabilized, and then you look what still needs adjustments, you can always go up and down as we talked about. But
Yeah.
we want, there's a few things I wanted to chime in there. One is, if you had a lot of PMS when you were younger, maybe you have certain underlying genetic SNPs that make it harder for you to metabolize certain hormones in a certain way. So you want to support those pathways. This is where the functional medicine aspect comes in very handy because it helps me to understand what is the B6 support that they need, what is the magnesium support that they need, what is the methylation support that they need, what are their pathways, and is it an issue of the metabolism? Is it an issue of not having enough hormones on board? Is it an issue of their receptors not getting the hormones the right way because they have some underlying toxicities that block those receptors, like endocrine disruptors, macroplastics, mold, stealth infections with viruses? You do want to optimize all of that because the hormones alone, they're very powerful messengers, but they have cofactors. There's certain nutrients they need. They need to be metabolized through the liver, then go through the gut bacteria, through the ostrobolome, and they have to be metabolized there and recycled. So there's a lot of things that contribute. For example, we know that women who have underlying gut dysbiosis are more prone to PMS symptoms. We know women who have methylation issues are more prone to PMS symptoms. We know people who are nutrient deficient in certain cofactors needed for their neurotransmitter balance are more prone to PMS. So hormones are important, but you want to understand the whole picture, and you want to make sure the levels are where you want them to be, the periods are where you want them to be, and then make modifications from there.
So if somebody's starting out with you, do
Mm-hmm.
you start with that functional medicine part, that piece of what is your gut doing, the methyl, what was the word?
Methylation.
Methylation.
Methylation. How do you test for those things? What's your protocol?
Ideally, I would love to do it for everyone because everyone benefits from it. But there is a little bit of a cost prohibitive issue for women. So often I just get them started on hormones, see how they do. And then if there are issues, I can look further. But I also get patients referred from health coaches that are running those tests. So a lot of them are getting those things optimized when they come to me, so we can address that. It's wonderful when it's all done together, but some women might have, not the money that they can invest in it. They want to get started on the hormones, and then we go from there. If they have
Okay.
issues or difficulties, then we can look further. I, I kind of try to avoid, you know, a lot of testing that can overwhelm them financially. In an ideal world, however, I would run this on everyone and kind of know where they are.
Well, yeah, because fixing gut issues, there's not like a one and done thing for that, it seems. It's like a ongoing.
Yeah, and it's complicated because we have our environmental factors contributing to that cause, leaky gut. We know that we have nowadays hybridized wheat that's sprayed with glyphosate and pesticides that can attack our gut. We have fluoride in our water that attacks our gut and our gut microbiome. But we also have the hormonal changes that change the gut microbiome itself. So sometimes it's just so many different factors. And I don't know if you're aware, but even COVID and the COVID vaccine definitely attack the gut microbiome. There's studies that showing that bifidobacteria significantly reduced in long haul COVID patients. So now we have COVID added to the mix in the last 4 years. So I have a lot of people with gut issues. But the decline of estrogen itself can affect the gut microbiome and the diversity of the gut microbiome. So a lot of it is like, what can we modify? What can we work on together in your lifestyle that can take care of it? And then are there certain supplements I know that broadly work for the majority of women? And if I still don't get success, then I would recommend doing the testing. It's several $100s. Insurance doesn't cover for it. I don't, throw it at you right off the bat because you might, feel overwhelmed financially. But if you are having issues that with all the things I do for you, with the supplements and lifestyle modifications, there's still things we don't dial in. Absolutely. I'll give you guys another example. I had a patient, I optimized her estrogen levels to the T. I got her up to estradiol levels of 350, 400. I know her estradiol wasn't underdosed. She was younger. She was early menopause with surgical removal of her ovaries. So I was more aggressive about the estrogen. She was 39, but she still just didn't feel good. So it wasn't just the hormones. And I optimized her thyroid. I do thyroid titration all the time. I have found that if I want to take care of women's hormones, I need to be an expert in thyroid as well. I can't just do progesterone and estrogen and ignore the thyroid. I did all of that and she still didn't feel great. And I ran some testing for her and she was completely mold toxic. So now I referred her, and she had heavy metals. So now she's working with a practitioner that I referred her to work on hair tissue mineral balancing, the mold detoxification she does for me. I work part-time in an IV clinic where we can do IV ozone and stuff like that can help people with mold toxicity. But I just use as an example of hormones are very, very powerful. And for the majority of people, that is all they need. But there are a lot of other factors that can contribute to how people feel other than hormones. So if you optimize the hormones and someone doesn't feel great, you might want to look further.
Yeah, it's great you do all that. That's
the
yeah, not real.
Yeah.
I think that's where it's headed. I think that's where everything's headed is this
Yes.
sort of more of that holistic approach. So good for you.
I think medicine is so fragmented. I will not forget that there was a person who was sent to a GI doctor for GERD and gastric symptoms, and they do endoscopy and a colonoscopy. Turns out she was pregnant. Nobody did ran a pregnancy test. Or we have people who, there's so much overlap. Like, you guys know with GYN, like endometriosis patient can present in so many different ways, and then it ends up being endometriosis. It wasn't, it wasn't something different. And so there is so much fragmentation in medicine nowadays that I find it's my role as a doctor to know as much as possible about different specialties so I can guide my patient at least to say, listen, I think there might be an overlap here. And people are not easy. Like people are getting sicker and sicker. I see so much mast cell activation. I see so much gut dysbiosis, food intolerances, liver issues, people being just sluggish and fatigued and brain fog. I can't say it's all just hormones. I think the hormones are extremely important, and estrogen is our most important hormone, and it can help a lot with our immune system and our gut microbiome. But again, it's really important to understand how it can overlap with other issues for people.
One of the things I think we run into with the PHRT is that it is more complicated than just putting somebody on a static dose. And there's so much more to think about than that, as you've just described. So there's more work for the patient. There's more work for the physician involved in this. There's a lot of time taken doing this because, as 25 years ago, this wasn't working for everybody. And and I stopped doing it. So I think being able to look at all these other things is very, very effective. But patients need to know, and as Karen was saying, is what's going to happen in 2 weeks when she's mid-luteal phase. And
everyone will know.
But some patients CE, meaning patience, having patience are important with this.
Correct.
We've got to just keep them going. Okay, this is going to be a few months to settle it down, but that's worth it because there are these significant benefits of being on rhythmic physiological HRT that we only thought of before, Susie Wiley thought of before, and they've come to fruition, whether it is the improvement in cardiovascular system or the protection of cardiovascular system with, endothelial progenitor cells being increased because of the hormones, or the P53, P27 protein tumor suppressors, and the much more significant help in preventing osteoporosis or treating osteoporosis. I mean, which we now have evidence for these things that are there because of these peaks of estrogen in the first part of the cycle and peaks of progesterone in the second half. Wouldn't you agree?
Correct. I agree. When you said people don't want the period, the problem is the period is not, nobody wants a period, obviously. But once you understand what the period means, you'll be happy to have a period back, because it will represent a lot more than just a nuisance of like having blood every month. It means that you got enough estrogen on board to grow the tissue, not only in the uterine lining, but to grow the tissue in the bones, right? To activate the osteoblast the right way so that you build new bone, to activate the nerve growth factors so that you build new neurons and brain cells, that you activate the endothelial cells, as you said, that you help the mitochondria in your heart muscle, that you can pump enough blood, that you don't develop congestive heart failure. Because not only do women develop high blood pressure and more plaque buildup in their vessels with lack of estrogen, they also are more prone to congestive heart failure, the heart muscle dilating. That's from the lack of estrogen on the heart muscle. So the period means you got enough of estrogen in all these tissues, and enough that you would build also a lining. But then whatever you build, you have to shed it. You can't just keep building, building, building. It also, you have to recycle the old senescent zombie cells. So that beautiful rhythm, Wiley was such a pioneer understanding that the menstrual cycle means so much more than just being an annoying bleeding. And when hormones are optimized, actually when estrogen is high enough in the first half, you stimulate cell arrest, but you stimulate the progesterone receptors to be performed adequately so that the period is not too heavy. We don't want you to have painful, heavy periods. We want periods to be a good flow, but not too painful, not super heavy. And the better your hormone levels are, the higher they are, the better that is controlled. So I think looking at periods that way can make it easier to understand for people. But it's an adjustment, and not everyone wants it. Not everyone wants that, and not everyone wants the fluctuations. And Karen, to your question about how am I going to feel, I think part of it is accepting it as women. We not only have a circadian rhythm, that's a 24-hour cycle that men have with melatonin and cortisol, melatonin at night, cortisol in the morning. We also have an infradian rhythm. That's a 28-day cycle rhythm. And all of our organ systems, for the majority of our reproductive life, from the first period to the last period, was used to that rhythm of the infradian rhythm.
Yeah.
And women, we're not meant to be the same throughout the whole month. We are meant to be having a little bit of ebb and flow of our mood, a little bit of ebb and flow of our energy. That was biologically, because if a woman got pregnant after ovulation, so the first half, nature wanted her to be outgoing and adventurous and meet a guy and have more libido and be more horny and have
Yeah.
sex and get the egg fertilized. But if the egg got fertilized, nature wanted her to calm down. stay at home, watch her health, eat more, build more
Yeah.
glycogen reserve in her liver, and sleep better and calm down and not be as social. Once we understand that as women, we don't function like men. We can function like men. Biologically, we're different and we live within this rhythm. It makes it a little bit easier to understand a little bit of the ebb and flow, because I have to say, on the physiologic restoration, even on the best hormone levels that I get women on, there is going to be a little bit of fluctuation of things throughout the cycle. That's just biologically how we were meant to be.
Yeah, well, I mean, one of the reasons why I'm doing it is really because I wanted to try it because I want to be able to talk to patients about it. Obviously, we're marketing it through the podcast and trying to educate as many people as possible about it, but also just in my own world, everything I'm doing. And as we age, all the upkeep being a woman, I mean, at night and in the morning, everything I have to do. And the vaginal suppository is the one thing that I just really forget a lot. And then I have pain with intercourse. And so I'm hoping it really helps that
Yeah.
it, yeah,
Yeah.
removes a step, you know?
Yes, it makes your life overall easier, because if your systemic estrogen levels are better, hopefully you don't have to use that much of a cream on your face or cream down there, because the systemic estrogen is supposed to take that over from inside. If you still want to add a little bit of localized, help down there, you can, but you're not just dependent on that, right?
Yeah.
Versus when you're on a lower dose static hormones, your systemic estradiol levels are never going to get that high on a patch or on a static hormone level. So you are dependent on using the vaginal suppositories, the vaginal cream. And I wanted to say, with the static, you have to keep the estrogen levels lower, because people will ask, well, can't you get my estrogen higher, but me not having periods? We cannot, unless you had a hysterectomy, get your estrogen levels really high, but tell the estrogen not to go to the uterus, but go everywhere else. The estrogen is going to go everywhere indiscriminately.
Mhm.
And so the moment you change someone to a higher estradiol level to get her serum levels above 60 or 80 picograms, you're going to be building lining, and that has to shed itself. So if you have someone on a daily same dose every day, she's not shedding it, she's going to have more of that unpredictable, unscheduled bleeding. And I find that more unnerving than a scheduled period.
True.
That
Yeah.
Definitely more unnerving,
Yeah.
because with any of these patients, if they have any unusual bleeding at all, we have to investigate that with ultrasounds, blood levels, and biopsies and so on. And that's
Mhm.
yeah,
that irregular bleeding is the bane of my life. Frankly, I'm not having the bleeding, but my patients are. So
yes.
it becomes an issue. We could go on for a long time, but I want you to quickly talk about these rhythmic hormones in the treatment of PCOS. What do you think about that?
I think that a lot of PCOS women are not estrogen dominant, they're estrogen deficient. And if you reinstate normal hormone levels with thyroid, estrogen, and progesterone, you can help them a lot with their PCOS, because you help the feedback mechanisms in the brain that are elevated, like LH, and then it overstimulates the ovaries to make too much testosterone. You can alleviate that, and you can help them have regular periods, and you can help optimize their insulin resistance. It depends on each factor and what type of PCOS someone has. I believe there's different phenotypes and
Mm-hmm. Certainly.
pathophysiologists to PCOS, but a lot of women fall into that category that I said, where they're low progesterone, low estrogen, high prolactin or high testosterone, mostly high testosterone, high insulin, high adrenal hormones like high DHEA, and often low thyroid. So bringing those hormone levels to normal can help. And but not everyone will need the same type of approach. I will tell you, what women with PCOS don't know is that they are at higher risk for metabolic issues once they are in
Yeah.
perimenopause, because they have lived with insulin resistance or lipid abnormalities or high triglycerides majority of their life. They often are battling weight gain issues and visceral fat. And so you got to be even more on top of it on their hormones in midlife and explain to them how important it is to normalize that insulin resistance, help with their metabolic health. And estrogen can be so helpful for that. And regular periods, regular cycles. And progesterone is super helpful for it as well.
I have a question about, would you be also using metformin, or you be using the PHRT instead of metformin?
It always depends on the level. I think that if someone had amazing lifestyle coaching and we could improve a lot of what the lifestyle looks like, and even the endocrine disruptors that come in from outside, like the microplastic, the BPA, we could normalize a lot without medication. There is going to be instances, however, where the insulin resistance is very significant, and even despite lifestyle changes, they cannot normalize their levels. And these are cases where, and I know that's controversial, but there are cases where I find the GLP-1 agonists helpful in a lower dose, like the weight loss
Yeah.
peptides. And then with metformin, I think that it can initially be helpful for women to help regulate glucose. But the problem is that it does elevate lactate levels. It does increase your overall tendency towards metabolic acidosis, which by itself creates a milieu for hormones and nutrients not to function perfectly. And it does increase a little bit gut dysbiosis. So it would be a temporary thing. The same with GLP-1 agonists. I wouldn't want to keep everyone on it forever, but it can help stimulate a little bit of metabolism. You can use some herbals like berberine or chromium for glucose metabolism support, but everyone has a different degree on insulin resistance. People also have different degrees at which they're actually implementing the lifestyle changes that were discussed. I think PCOS patients are the type of patients that would benefit very much from a holistic coaching approach where there's a lot of, exercise routine implemented. Really, the diet has to be dialed down to a T, and things like that. But I wouldn't say it would be in place of it. I would say it's in conjunction with everything, the hormones.
Okay, I have a serious question for both of you. In this whole menopause revolution right now that's happening all over, you've noticed it. What's your opinion about? I'm noticing that places are just popping up and everyone's now prescribing, right? HRT.
Mm-hmm.
And people that aren't qualified, haven't been trained, that are just kind of hopping on the bandwagon to get on board the bus for profit. What are your thoughts about that?
Well, I think one of the things that are popping up a lot are palate clinics. Don't you have you noticed that?
Yes, yes, yes.
I think it's because it's easy, right? You do a weekend course. I did it. I have been trained in pellets. I've inserted over 500. The training wasn't extensive. You get a little booklet and you get started. And because they're mainly testosterone dominant, they're easy to be done because you don't have to deal with estrogen and bleeding and all of that, right? The problem is they're not physiologic way of giving hormones back, and you can actually cause a lot of problems for women with them. And you're not really optimally treating women's hormone levels. You're giving them kind of a roller coaster approach where they go up, they peak around the week 6, and then they go down. And so the first half of the pellet, they get too much, they have to start really high, get peak around 6, and then they decline from there. Then I also see a lot of people popping up saying they're menopause experts and prescribing generally hormones. And it's good that we are democratizing it more and making it more available to women. In my practice, however, I get a lot of women who get started with providers that might not be that educated, and then they realize the levels aren't optimized or their symptoms aren't really well taken care of. And then they come to me for optimization.
You're absolutely right. And it's we are seeing a lot of this in our little piece of the world in Santa Barbara, where, for a long time, there were just a few of us prescribing hormones. Now, just on the street we're on in Montecito, there are 3 or 4 different places prescribing hormones, and some of them are using pellets and only trained with the pellets. And these are not, the important thing is that none of these are OBGYNs. None of them are gynecologists, and none of them know how to deal with the problems. Nobody takes the precautions of doing routine ultrasounds on these patients, just looking for endometrial hyperplasia or at least endometrial thickening. So it's very frustrating. But you are extremely eloquent, and I mean, you can make a case so easily to come to an expert like yourself, and I have the benefit of many years of experience in it, and feel like I really have something to offer the patients as well. And it's just frustrating, and I think that the word needs to get out that this isn't just as simple as prescribing a patch and a pill, and that you've got to look after the body as a whole, the woman as a whole, and deal with the other things that can come along with this, that, such as genital urinary syndrome of menopause, which is horrifying for women. And I mean, that only got a name in 2017. I mean, I guess no woman had any genital urinary syndrome prior to 2017. Obviously, that's not accurate. But we've got so much to offer these patients, and it shouldn't just be somebody, a nutritionist or a naturopathic doctor or just any MD doing this. It's patients need to be in the hands of somebody who's doing this all the time and really understands it and knows about it and can continue to improve.
I do think it's wonderful that you have your practice where you can see them in person, because there's so much I can learn from just looking down at the vulva. I can do an exam. I can check for sensation with a Q-tip. I can examine the clitoris, the size of the clitoris, the hood. I can do an examination of the vaginal epithelium. You and I, we can do bimanuals. Just from bimanuals, we can palpate, nodules and tension and trigger points. And there's just so much we can do. And I love that. I wish I could see all my patients in person, but I do offer telemedicine out of state. And I do emphasize that they still need to have a GYN that sees them once a year at least, because I can't do the exams for them virtually. And I agree with you. And then you have some tools in your office where, even though when you optimize hormones, for some women through time, there is some communication issues between the nerve endings and the tissue and the brain and the vagina, and the libido doesn't all kick back all the time because the sensation has gone down there. And then you can use treatment modalities, and I like to offer those in practice where I am too, where we can help them regain some of those things. And I think that plays into the holistic approach as well. Hey, how can we optimize your sexual health or your vaginal health with, is there a prolapse going on, or is there urinary incontinence going on? Optimizing estrogen will help, but in some cases you need a little bit more. And it's great that you have those tools in your practice for them. That sets you apart.
We're very fortunate, absolutely. I think, I don't really like your opinion on this, the patients that are very difficult to manage are the perimenopausal patients.
Yes.
Because their ovaries are working some of the time, misfiring at other times, and irregular bleeding is frequent. Moods the patients often have full-blown symptoms of menopause without the necessary 1 year without a period definition that you have to give, or an FSH level of 75 or 100. So what do you think about that group of patients being good candidates for rhythmic physiological HRT?
So I think that it can be a great solution. I think more and more data is coming out that all these comorbidities that we talk about that women suffer from in midlife that really gets worsened in menopause, where menopause is really just the point of no longer having periods and no longer making those hormones. Those issues with cholesterol, high blood pressure, anxiety, mood issues, sleep, urinary incontinence, vaginal epithelium changes, skin thinning in everywhere in your skin, hair thinning, libido issues, that starts many years before that. It starts
Hmm.
already in perimenopause. And there's data coming out that, you know, uh, it might be better to start addressing these cholesterol changes and metabolic changes and liver health and
Yeah.
insulin resistance way prior to that. Physiologic restoration can really help. There's two ways to address perimenopausal symptoms for women. Some people, like the standard approach, is to give them a low dose estradiol patch and progesterone and cycle that and just support their own body in what it's already making and not overrule it. But I think depending on severity of symptoms and what the own production is, if I take it over with for them with physiologic restoration, I can optimize their levels a lot
Yeah.
better than their own ovaries would. And that, that can by itself just normalize so much because you're taking over the FSH feedback loop and it will take away a lot of that's up and down and roller coaster and severe symptoms that come with the ups and downs. But yes, once in a while, their own ovaries will still, contribute and kick in and bring those levels up. But overall, I think it's beneficial, depending on the symptoms, to start earlier for people. And this is something that I'm still experiencing myself with the patients, because in my experience, when I explain to the patient, you're still making estrogen, but you're making 20% less than you made five years ago.
Right.
A
Hmm.
lot of them don't want to give up on their own production. They don't want me to take over the system. So they want me to just support it. But once I actually take over, they feel so much better. It's
Yeah.
easier to address it, to accept it. So,
Yeah, I think because they don't realize how much things have changed because they've changed slowly. So as
yeah,
soon as you really kind of
yeah,
show
yes, correct.
them, you know what I mean? It's like
Yes, that's correct.
people getting vaginal rejuvenation. They don't know. They think, "Oh, well, I don't really think I need that." And then they have it and they're like, "Oh, wow, I really
Yeah.
needed that."
Yeah,
So,
it would be great if we could check like visceral fat measurements for everyone and check their insulin and their cholesterol markers and just show them how those things are trending upwards already. And that would be like objective markers that they can use for the metabolic health and see, hey, you're right. Like these are things that are happening to me, but I haven't changed my diet. I haven't changed my lifestyle. I haven't changed my exercise routine. Also, there's going to be a subgroup of women that are mentally very susceptible to even minimal estrogen decline, right? So ADHD people, bipolar disease, people with OCD, people that they're very dependent on their neurotransmitters to be optimized. And we know that just for ADHD people, the changes of estrogen in perimenopause can quadruple their symptoms, right? So if
wow.
you feel like you have always had ADHD and it's always been hard, but now you have even harder time to focus or even less motivation or more, less joy, or you are more depressed or more anxious. Those things are hormone related. And maybe that might be an argument where women would be more amenable to me starting them on hormones earlier. But I do think, honestly, in 10 years, we'll be there. I apologize, my voice giving up. Where we will optimize women's health way prior to menopause, because we will understand these things are linearly developing over years. This is
Hmm.
not an overnight
Yeah.
thing. You woke up and just because now you're menopausal, all these things are suddenly starting. No, we're just noticing them, or we're maybe just now testing for it. But if you want to optimize it, you might want to start a few years prior to that.
Right. It becomes more of a preventative
Preventative.
treatment. Yeah.
Exactly, which is what we never focus on in medicine the way we're trained, right? So I think it's going to go more towards that, but it is going to take years to get everyone on board with it.
unfortunately.
We have yes, you're right. It is going to take a while. We've been doing testing almost pretty routinely on these patients for insulin resistance, just giving a good look at their lipids, good look at their metabolic situation prior to doing any of the replacement hormones. But in fact, every new patient that comes into the office gets a pretty intensive screen with looking at metabolic disease and looking at cardiovascular disease. So,
and most of them say, I've been getting lab work forever and I've never had these tests run before. So
yeah,
right?
fasting insulin, cortisol levels.
Looking at the things like, heart health and inflammatory markers and things like that. So
Yeah.
So
exactly.
we could talk for days, I think. We need to have you back, or maybe even better, have you come to Santa Barbara.
Why are you in Florida? How did you end up there? And then we'll let you go.
Yeah, I have two cousins here, and then when I was in Maryland, I wasn't when I exited the hospital system, I kind of wanted to be here. It was during COVID, so I appreciate the way things were handled here more than where I was.
So how long
Yeah,
have you been there since COVID?
for 3 years now.
3 years.
Yeah,
That's
and
great.
it's nice. It's a nice area. It's obviously the climate in California is pretty optimal. I think it's the best in the whole country. But out of the monsoon season, I do like how sunny it is, and then there is a beach, and it doesn't get you have a little bit of you can get to the beach and cool off and ground. I do miss mountains, and I do try to get mountains once a year at least, go out there. But yeah, it's a nice area, and it's growing, and it's quite popular, and we're close to Tampa, and it's a young city and a college town. So yeah, it's a nice area for sure.
That's good.
Yeah.
Do you have anything else?
Oh, no. But other than thank you, you've been tremendous. It's been great talking to you. I've learned a lot from you and appreciate
Beautiful.
your
Yeah.
focus on detail of this. It's really tremendous. So thanks
Sure.
very much.
Thank you so much.
Well, thanks for listening. We're getting really good feedback. We'd really appreciate a review on Apple Podcast, Spotify, or wherever you're listening. Thank you. You can always DM the Vagina Doctor Instagram with any questions or topics you'd like to learn more about, or email us. The Vagina Doctor Podcast. It all starts here.